So I'm going to be talking today on diagnosis and management of craniocervical dissociations. Just so you know who I am, my name is Rick Bransford. I work at Harborview Medical Center, a Level 1 Trauma Center based in Seattle, Washington, part of the University of Washington system, and we cover a large landmass of the United States of America. For full disclosures, these are the ones I have. Nothing should be relevant to this particular discussion, and nothing should impact this. So let me start with just a presentation of a case. This is a 34-year-old male. He was an unrestrained driver in a rollover motor vehicle collision. He presented to the outside facility with an obvious hemopneumothorax for which a chest tube was placed. He had an unstable open book pelvic fracture for which he was placed an external fixator. And according to the x-ray seen here and some other imaging, his spine was cleared, ATLS was complete. However, unfortunately, 48 hours later, he developed weakness in his right upper and left lower extremity with motor scores of 2 to 3 out of 5 that apparently were not there at admission. His CT scan is shown here, and the information is there. However, there's a frequent saying that says the eye sees what the mind knows. If your mind knows what to look for, you'll see it. If your mind doesn't know it, it's going to miss this. And so you can see there's some subtleties here, and we'll come back to these in a little bit, but essentially these were missed on the initial read by the outside radiologist, and so therefore were not transmitted on to the ER docs, the trauma docs, and so on and so forth. So let's kind of move on from there. So if we look at the occipital cervical junction, this is really defined as the occiput to C2 region. So if we look at where dissociations can occur, we see that about 41% are going to occur at the occipital cervical junction as demonstrated here on this slide on the right. We're going to have about 23% at the atlantoaxial articulation as demonstrated here between C1 and C2, and about another third, roughly 35%, at a combined occiput to C1 and C1, C2 as demonstrated here. Now, if we look at the ligamentous attachments, and we'll look at this on the next slide, these are really disrupted between the occiput and C2, as this is really kind of a common area in each of these. And the other thing that can be affected are the joint capsules, and maybe that's what's keeping these together. If we look again at sort of the anatomy here, where so much of the rest of the spine is held together by, yes, by ligaments and discs, but also by bone, there's very unique attachments here that allow for the significant range of motion that we see between the occiput and C2. There's a tectoral membrane that kind of prevent distraction. There's the alar ligaments that prevent distraction but also help with control of rotation. We have the capsules between the skull and C1 and C1 and C2, and also control rotation. And of course, then we have the transverse atlantal ligament at C1, C2 that prevent that translation between C1 and C2. Now, as we look at craniocervical dissociation, the correct diagnosis has to be made, and this is critical, and this is frequently where the errors are made. There are a lot of subtleties that can happen here. We can have type 1 Dens fractures that really are not so much a representation of the fracture as an avulsion of a ligament pulling off a piece of bone. Likewise, and the most common one is really these type 3 occipital condyle fractures, where essentially our alar ligaments are pulling off a piece of bone that also can be an indication of craniocervical dissociation. We need to look for soft tissue swelling. There can be these unusual C1 anterior ring fractures, and of course subtle subluxations between the occipital condyles and C1, or distraction or subluxation between C1 and C2. If we look at this historically, this is an article that came out of Harborview Medical Center, and we look at this high rate of missed injuries. If we look at this historically, 50 to 75% had missed injury rates, and these were defined as delay in diagnosis or things that were not picked up on initial imaging. Unfortunately, this led to approximately a third of patients developing neurological deterioration, and really the reasons were lack of suspicion or inadequate radiographic screening that really did not pick this up adequately. And again, these can be quite subtle. This led to mismanagement and led to sort of demise of patients that could have been avoided. Now, why is this happening? Well, here's a study we published back in 2010, and essentially what our radiologists in the emergency department are looking for is one of the main things we're looking at is Harris lines. And we're looking for normal Bayesian-Dens interval. We're looking for normal BAI. However, when we looked at 48 patients who had survived, normal BDI and BAI occurred in over a third of patients, or 11 out of 48, representing 35%. So if this is really all they're looking for, the radiologist may miss this, and therefore there may be a failure of communication from the radiologist to the ER staff. The ER staff and spine may never be consulted, whether neurosurgery or orthopedics. This is an important issue. If we look at classification, this is a grade-based classification that came out of Harborview, proposed by Jens Chapman in 2001. And really this was designed to help guide treatment and also indirectly associate prognosis. A stage 1, as defined by us, basically represents a minimally displaced, no really significant dissociation, and these are really sort of more of a sprain where there's some subtleties, but really overall things are stable. The stage 2 represent minimally displaced with dissociation, and really these ones should be managed with occipital to C2 fusions, but these are really the dangerous ones, and we'll discuss that further. The stage 3, these are highly displaced occipital cervical dissociations, and really again, a posterior spinal fusion from occipit to C2 should be done. Now, as you can imagine, stage 3, with significant distraction, they have the worst outcomes because the spinal cord is under tension. Stage 2 injuries, however, tend to be the more dangerous ones because they can be subtle and frequently can be missed, and this can then lead to neurological deterioration. Again, this is where traction testing can be done, and we'll discuss this in more detail. And really, I think we've come a long way in being able to use this traction testing to really distinguish stage 1 from a true stage 2. If we look at a guide to treatment, there's a definitive algorithm. The widely displaced or the type 3 injuries, we really want operative stabilization as soon as possible, and this typically is going to involve a posterior occipital cervical fusion. The minimally or undisplaced injuries, they can have subtle X-ray findings. Maybe there's some further evidence on MRI, and this is really where a traction test may be useful to try and figure out if this is really stable or if this is a type 2 where it looks like it's well aligned, but really it's quite unstable. If there's with traction test, if there's distraction of more than 2 millimeters, this would represent instability. If less than 2 millimeters, this would be a type 1 and can be managed non-operatively. So how does this look radiographically? Well, if you compare these two films, you can see here on the right that the occipital condyle is well aligned in C1. However, with some subtle traction, we can see this distraction here, and also notice this significant soft tissue swelling here. So this is quite subtle on the left, but when we provide traction, we can see it's much more unstable. We wanted to kind of validate this study, so we did a cadaveric study, and you can see our information here. This was published in the Spine Journal back in 2016, and we can see that using this red line here, you can follow this and see that really, as we section the various components that support this, we suddenly develop this significant instability, and I'll show you a video that demonstrates this. So again, look at the video here above as I sort of talk through this. And what we did is we sectioned these in varying orders from intact to bilateral alar to tectoral to unilateral capsules to bilateral capsules. And again, we varied the order here, but essentially we reached this all or none phenomenon where really there was no significant distraction of more than 2 millimeters until we hit the 5 to 10 pound limit. Only when all ligaments and capsules were cut did we see the significant distraction. And so as you follow this video, you can see us go from intact to bilateral alar to tectoral to unilateral capsules to bilateral capsules, and this is really what occurs. So this really becomes an all or nothing phenomenon. So now that we've made the diagnosis and hopefully made it well, how do we manage these patients? Well, these patients should undergo at least an occipit to C2 in a relatively expeditious manner. In positioning for surgery, if they're not already intubated, many of them are, we want a fiber optic intubation, obtain best possible alignment while supine, get baseline electrodiagnostics versus a wake-up test, Reassess alignment as soon after prone positioning as possible, and we really want to avoid traction on the shoulders, trying to compress the head and end up with some sort of occiput to C2 fixation. So we see here C1, C2 screws. We see, if necessary, C3 lateral mass screws, some sort of allograft or autograft to try and provide fusion from the skull to C2. This is what we're going to look like. And we can see that with current day fixation, we have a plate and screws here that are much more user-friendly than what we used to have, and we're going to end up with a construct something like this. Now, we know that surgical stabilization is now neuroprotective because now the skull is reattached to C1, C2, and we're not going to have distraction here on the spinal cord that can lead to further problems. We have to be aware of malreduction. So here's a 28-year-old female involved in a motor vehicle collision, and you can see on this initial film that she's distracted a little bit. So end up repositioning the rods and screws. We can see that now she's much better aligned here between the occipital condyle and C1. And here's what her postoperative CT scan looks like, showing a very adequate reduction. We also need to be aware of cerebral vascular injuries. We did this study back in 2014. We had 29 patients with vascular screening, and over half of them had a blunt cerebral vascular injury, somewhere in the carotid, somewhere in the vertebral arteries. These are important to know preoperatively so you know how to manage those, and sometimes maybe a C2 or C1 screw is not going to be an acceptable option. You have to vary your fixation as a result of this. There can also be anomalous vertebral artery anatomy. If we look at this initial study that came out in 2012, there's a 10% prevalence of unusual vertebral artery anatomies. All of these had skeletal anomalies with occipitalization of C1 or os odontoideum. Here's a particular series of CT scans on a patient we managed, and you can see it here on the right. We've written up 2 cases of these where patients had unusual occipitalization and unusual anatomy. And if we look at this in more detail, you can see here that this vertebral artery, the C1 arch, is assimilated to the occiput on one side but not the other side, and this vertebral artery is coming between C1 and C2. This is important to know preoperatively. In terms of alignment, it's important to ensure that we have adequate alignment. Here's a study we just published this year in 2020 where we have used this technique for a while, where we try and line up the posterior mandible with the anterior aspect of C2, and that really seems to be reproducible, an easy measurement intraoperatively, and allows us to line up things in appropriate alignment so that basically people can swallow and have horizontal gaze that is acceptable. This patient on the left, we want to avoid this type of fixation here. As we've gotten better, this has led to ethical challenges. This was a 17-year-old male in a motorcycle accident. He was cognitively normal. He wants everything done possible. But as you can see here on this right film, he's got a transection of his spinal cord. He's got a very poor prognosis. So back to our case, 34-year-old male. He's got a hemopneumothorax. He's got an open pelvic book fracture. His spine is cleared. This was not recognized that he had translation or subluxation of his occipital condyle over C1. He also has significant soft tissue swelling. The information was there. We can see this occipital condyle fracture. This is a type 3. We can see it again here. We can see the subluxation. We can see the subluxation on the other side. All the evidence was there. We also see this distraction between his clivus and his tendons. So, unfortunately, he did not undergo early posterior occipital cervical fusion. This was delayed, but eventually was done. Case resolution, he had full recovery, fortunately, of his neurologic function. He underwent a healed occiput to C2 posterior fusion, and he was able to return to work 6 months later as a bartender. So in conclusion, it's important that we make an early diagnosis. This is important to outcome. It's important to sort of the long-term recovery of these patients. Stage 3 and Stage 2 should undergo early fixation as soon as possible. Stage 2 are the dangerous ones. Stage 3 have the worst prognosis. And again, most of these are going to require a minimum of an occiput to C2 posterior spinal instrumentation fusion. Thank you for your time.